Hello, everyone. This is Cole from the American Journal of Healthcare Strategy, joined by a special guest, fellow Pennsylvanian, Dr. Maselli. Dr. Maselli, please introduce yourself and your role.
Sure. I'm Kurt Maselli. I'm the Chief Medical Officer at Elwyn. I've been at Elwyn for about 6 years now, and I really oversee the health services and quality for Elwyn.
Thank you so much for coming on. It's a big honor to be able to talk with you. You have so much experience. It looks like you started your residency or finished your residency rather back in 2008, so you've been practicing for a long time now. I want to ask here, what got you into the field of psychiatry? Why did you originally want to go into medicine?
Well, certainly, first off, thanks for having me. Really appreciate being on the podcast here. My parents envisioned that I would be an ear, nose, and throat doctor, and I would take over my uncle's practice. Granted, my uncle had a wonderful practice and really inspired me to be a physician. But I would say it was that third year medical school rotation, oddly enough, at the Eastern Pennsylvania Psychiatric Institute, which is no longer open, EPI, right next to MCP, which also unfortunately closed. But nonetheless, just being on the unit, seeing adolescent girls really receiving psychotropic medication to help make them better, it really sort of struck me in a very powerful way that, wow, I wonder if I can do something to really help these young people and help really anybody with psychiatric illness. And then certainly as I did other rotations in family medicine and internal medicine and even in surgery and such, the theme was clear that behavioral health issues were through it all. And especially in family medicine, I mean, a third of the folks that were coming in were really coming for behavioral health needs. It interested me. And as I looked at opportunities, I was very fortunate to find a combined program with medicine and psychiatry. I always thought internal medicine was also fascinating, and UVA had a combination program in Charlottesville, Virginia, and I was fortunate to be part of that program. It was a great experience. It really taught a lot on both the medicine and the psychiatry aspects, and was very fortunate to be with some really great mentors and peers.
I didn't realize it was a combined, and I see that, of course, in the resume now that you mention it. But that is pretty unique, and I think that is very interesting. I have to ask as well. You were a resident, I believe, when you started your MBA. Is that right?
I was just finishing residency, and as I mentioned with EPI and with MCP, that unfortunately those hospitals both closed. And so the other thing that was also piquing my interest at the same time of psychiatry was just the fact that, wow, if you really don't run a hospital, or hospitals can go out of business, and that was something that really struck me very powerfully, and it made me wonder that, is it possible for me to help continue the role of healthcare as a physician leader, as a physician executive, to offer that expertise as opposed to a purely non-clinical point of view or expertise. And granted, I think one of the things I've realized is that it's tough running a hospital or running an outpatient practice, or running any piece of the healthcare system. It's a challenge, and certainly I like to always wear that clinical hat to remind myself as to why we do what we do in terms of caring for patients and really aiming to make their lives better. So yeah, it was the business school aspect was a fortunate part. As I was just finishing residency, I had applied to Darden at the University of Virginia, and they let me in, and it was a great experience. I was one of the few physicians that were there. I think over time, MBAs are becoming more and more popular with physicians, but it was a phenomenal experience to be with folks in finance and other industries, especially in the 2008 to 2010 period where we had the financial crisis. So it augmented the experience, and I had the opportunity to work a little bit at UVA as an attending physician, and also at Western State Hospital, which was the state hospital out just some miles west of Charlottesville in Stanton, Virginia.
Because you also were a summer associate at McKinsey, right?
That is correct. So during that year that I guess the 2 year experience that I was with Darden, I thought that perhaps I would want to do consulting, and the opportunity availed itself that I could do the 10-week summer period of time at McKinsey, which was just a tremendous experience. I mean, it's amazing to see the individuals that work there, the professional degrees that many individuals had. It made me think that it humbled my own education. I'll say that, and it was just, again, another great piece of the view into healthcare, being a consultant, helping in that case, again, it was only 10 weeks, but it was primarily pharmaceutical companies providing consulting on some drugs and such in terms of marketing. And there was also a piece of the stint that went into some policy formulation. So it was, again, a phenomenal experience with phenomenal folks. And, again, I've been very fortunate and blessed to have been part of some really great teams throughout my career.
And so you have a lot of experience, right, coming out of this, and then in about 7 years, you become the chief medical officer of Bancroft. A little bit before that, you start teaching at Villanova, healthcare economics, right, during in their MBA program. But what got you into leadership? Like you said, you looked at consulting. You were a well trained physician. You were chief resident of your residency program. So you probably had a lot of options of different things you could have done, right? You've been very successful. What
Yeah.
made you want to go into leadership as a chief medical officer for Bancroft? What was the cause of that?
Yeah. So again, as a clinician, there's the physician-patient relationship is something that is definitely sacred, and I value it with my own physician, and likewise, I hope that many folks have that same opportunity with their physician. I thought I could perhaps do more, and that was perhaps the biggest driver. That it's great to be helping folks on an individual basis, and granted, in my time in crisis at Crozier or whether it was at Fairmount Behavioral Health or various situations, it was phenomenal to be able to help folks on that localized individual level. However, I thought there could be something greater, maybe from a population point of view, and how could we really drive care to a better degree? And frankly, I wondered about administrators and thought and questioned, well, is that really the right decision? That doesn't really make sense to me, the clinician. That isn't helping me, the clinician, in the context of supporting the patient. And granted, being on the other side of the aisle, I think I see some of those decisions perhaps a little bit differently than I did initially, as you, again, with experience, gain some different perspective. But at the same time, my focus really has always been, how do I make things easier for the clinician so that the clinician can do what we ask them to do? And that's provide exceptional patient care, client care, whatever the relationship is with the individual that we're supporting. And that's really been the primary focus of my mission, is wanting to make life better, make life easier, supporting those folks that are, the employees of the organization, so they can be successful. Because if they're successful with the individuals that we support, the individuals will be successful, and we'll be getting great results. And so then, as the quality leader, really sort of seeing those results will come to pass and materialize. So it's been quite a journey, and likewise, I mean, frankly, seeing MCP hospital go under and Epi close, it's very real, and it's been very real in Philadelphia. There's been tremendous movement in the industry here, whether it is through closures or consolidation, and it always makes me really go back to, could something be done better to have preserved, saved those institutions, those pieces of the healthcare system, or maybe not. Maybe the outcomes are what they are, and we can do something better. I don't know. But it does make me wonder, and has made me wonder, and driven me to be more administratively involved. And again, it's been a phenomenal experience.
I think one of the questions that I have, right, is we have pent up demand. We have a lot of demand for psychiatry services, behavioral health services at large, right? Because it seems like we do, because the wait times are really long. Um, but thinking back to my freshman year macroeconomics class, it feels like if there's this demand and this opportunity, then why are institutions closing? Why are the present institutions having a hard time, paying staff or getting enough doctors? I mean, not to overgeneralize, but what is kind of the issue? Because it doesn't really
Yeah.
make rational sense, right?
You would certainly think that in a free market system. And the reality is, we don't have a free market system. We've got a system, again, not necessarily good, bad, or indifferent, but the system that we have is very much a system that's oftentimes based and indexed on the prices that CMS has believed to be those that are set. And truth be told, we go over this and much in the Villanova course that I teach. When you look at those relative value units, those units that are assigned to the degrees of care that we provide, whether you get 3 points for something or 5 points or whatever those units are, and then you multiply it by a dollar amount that's actually set by Congress, the conversion factor, you can actually figure out the Medicare rate. And oftentimes, many of our private insurances will mimic that rate or multiply it by a factor of whatever, another 20%, 30%, whatever it might be. The challenge has greatly come to pass that perhaps those rates for the cognitive sciences really aren't enough per se. And I know that oftentimes there's a conversation in the medical community that the proceduralists tend to do better in terms of the number of points they get for the RVUs. And no fault to them. I mean, heck, I'm not a neurosurgeon, and that's not what I'm doing. And I totally understand that that's highly skilled, highly dedicated piece of the workforce in healthcare. However, on the behavioral health side, we have our degrees of cost, but or our the revenue that we can potentially generate, but we also have significant costs just in the fixed costs, and really those are oftentimes the labor units, and even at an organization like Elwyn, where I look at that, labor is 70% of really our expenses, so it is the driving force, and there are a lot of impacting factors there, making sure that clients are showing up for their appointments. Telehealth has been great in allowing and improving the access to care, and it has also helped to improve the number of folks who are showing up, because perhaps if you can't make it in the office, telehealth is easier. You can just turn your computer on or get somebody on the phone. So that has definitely helped with our organization. But the demand for clinicians and the workforce has changed, and COVID has been a significant contributor to that change, in the sense that we move very much to a lot of telepractice, and frankly, there are a lot of telepractices that have spun up, whether those are publicly traded companies or whether those are local to the area and such. And so there's a tremendous demand on the labor part of this as well. And so I think we've seen significant expenses rise there, which is, again, great for clinicians who can then earn more money and that sort of thing. However, for an organization, and an organization that perhaps deals with mostly Medicaid or managed Medicaid services, which tend to be lower than that baseline Medicare rate in their payment, that could be a challenge. And especially when we're competing against other organizations that perhaps have more access to commercial clients, where, again, the rate is greater than the Medicare rate, that puts pressure on, again, a nonprofit like Elwyn or Bancroft or such, whereby we are potentially getting less revenue per client that we're seeing, but in the same labor market, competing for the same labor units. I'd love to think that if the healthcare system were maybe structured differently, perhaps we would see different results. Again, they might not be better. They could be worse, or perhaps they could be better. But no doubt that the access issue that you point to would certainly make one think that, why isn't there more being done? But when you start getting into the weeds of it, and you start looking at the revenue versus the expenses that one has, the equation turns out to be a little bit different for the practice.
And so, one of the things I want to touch on too, though, here, you have the payer mix problem, right? But then you also at Elwyn, what does that look like in terms of the percent of people who can use telemed versus those who require in-person appointments? When we look at a Medicaid population, at least our Medicaid population, they require usually more in-person appointments. And so it's kind of a double, right? A doubly big problem, right? Because not only are we dealing with a more resource, intensive situation, but you're also, having individuals who struggle to really access the care that is resource intensive. What does that look like at Elwyn? This episode of The Strategy of Health was sponsored by Modality Global Advisors. Modality Global Advisors optimizes hospital revenue, enhances patient experience, and delivers proven results. Visit modalityglobaladvisors.com to learn more.
Yeah, no doubt. And at times during the pandemic, or really when we were in the thick of the pandemic, there was money thrown at us in terms of, hey, if you need money to buy iPads for people or such like that, fair enough, you can use that. And again, certain areas in certain states as to looking at different types of dollars that were federally available. And that was certainly very helpful, whether it's for our clinicians to allow them to work from home, or potentially some of our clients to stay connected. Many of those, we're in a different world now. We're back to the pre-COVID world of financing of healthcare and such. And so I think the challenges that you bring up are the challenges that we do see. And again, I mean, there can be technical limitations, whether it's a Medicaid population, or maybe it's older individuals, folks who aren't as familiar with technology. So whether folks have access to the technology or are unfamiliar with the technology, those are barriers potentially. And Fortunately, from a regulatory standpoint, there's been some allowance for using the good old-fashioned telephone. Those allowances will probably go away as time moves on because there is something that you get. Again, you get the most from an in-person visit. You can see someone completely and such, and feel them, touch them, and that sort of thing. You get more, obviously, from a video than you do just from the audio only. So we certainly really want to help encourage folks to do that. But we do recognize that there is a segment of the population where the telephone is the way that we're communicating with them. And certainly, our argument and our advocacy is very much for the fact that we want to support individuals where they are. And this is one way to do that. And so, that's the conversation that we have with the payers and such in terms of making sure that these allowances continue. Again, we're one voice in the sea of voices, and so there are other voices as well. And I would suspect that they're saying the same thing. But no doubt there are limiting factors, there are challenges. However, I would say that being in the world where we are today with the allowance for telehealth, we are in a much better situation than we were before COVID. And in a very weird way, COVID again has been awful with all the people that lost their lives as a result of it. But in terms of what it did in accelerating the acceptance of telemedicine and particularly telepsychiatry, I suppose that's a positive outcome. I mean, again, it's a bizarre way. I wouldn't really want to say much is positive from COVID, but at least it has forced us to look differently. And I don't know if we would be where we are today had it not been for a pandemic that really forced us to think differently. Whether that's because of the slowness of bureaucracy on the government side, or the slowness of organizations on just developing technology, or the slowness of clients and patients to accept it as a legitimate modality. So I do think we are in a better place. I mean, no doubt our no-show rates are significantly improved. I mean, we were an organization that would have almost 50% no-show, which certainly is a death knell for any practice. And also really makes you worry and want to figure out ways of connecting with people to make sure they're getting the treatment. For whatever reasons, could be a very innocent reason that they can't make the visit. I mean, heck, maybe they don't have the bus fare to get to the office. There could be other reasons. Maybe they're just terribly depressed, and that's we want to obviously address that and such from the medical perspective.
Yeah, no, and I think I do get concerned as well at the potential of telemedicine kind of exacerbating the issue, because we've seen where sometimes we can kind of just throw telemedicine at a problem, and then we don't always address some of the underlying public health
Mhm.
concerns. And what I like kind of about your approach is you guys have been trying to address these concerns all along, and then
Absolutely.
telemedicine is just giving you a boost. I do worry though, and I want to ask, a lot of it comes down to focusing on the patient, focusing on the client, which you throughout your career have been very clear that that's something that is your focus. A lot of the administrators who listen to this podcast, like myself, are not clinicians. We don't have that direct patient care experience. Is there anything that administrators who are not clinicians should be aware of or should do to try to enable that relationship that you were talking about earlier, to enable that member experience or patient experience?
Yeah, yeah. One of the things that I've seen administrators do who aren't clinicians is literally walk the beat, go to the homes, go to the offices, see the encounters. I mean, granted, not necessarily sitting in the room with the patient and such, but being there to at least maybe see the waiting room, or to again see other areas where one can meet clients, meet clinicians. Certainly, another avenue is obviously talking to the clinicians. And again, I mean, I think there are many administrators who do that and do it very well and do it very effectively in terms of keeping the lines of communication open. I suppose I thought I needed to get the MBA in order to have the sheep's clothing so that the business folks would listen to me, or at least invite me to the table. So I suspect that the opposite can well be true for someone who has the MBA and is looking to partner with the clinicians. I think clinicians are always interested in chatting about whether it's their research, their clients, the experience that they have of providing the care. And ultimately, I suppose the beautiful thing about it is that we're all patients, or we're all clients at some point in time, right? And so we all know what it's like to be on the other side. And I think that can be a means of connecting with the clinicians to help understand and to help bridge some of those divides. But we're only as good as our clinicians and the folks who deliver the service, and so being part of their hearing their voice and responding to it. And likewise, if there are things that the clinicians think, and perhaps things that I thought when I was a resident that I would think, oh, this is so silly. How could anyone, from administrative level allow this? And now I sort of like, oh, now I can understand it. I think having that conversation, having the open dialogue, building the relationships. I suppose it's in some sense my own version of Psychiatry 101. It's all about the relationships that you have with people and nurturing them, developing them, so that you can have honest conversations and you can give honest feedback to the clinicians. Not that it's a yes to everything, because yeah, there are going to be times where maybe it doesn't make sense from a different point of view and a vantage point for how we're moving the organization forward. So I think again, for embracing good people with kindness and compassion, and treating each other as we want to have our clients treated, that will set a great tone and I think build a great relationship between any person in administration as well as those folks in the front lines.
Very important advice, and I completely agree with it. I've seen that firsthand where we have the administrators in the hospital who are shadowing the physicians who are talking to the patients about their problems, and it makes a huge impact. Like you said, there's the most important part of the organization. It's the people. It's so important, but yet we struggle to recruit and retain still. Even organizations like yourself, I mean, there are struggles because the market just simply seems to not have enough physicians. Where do we go from here? What do you think is going to happen, right? Because a lot of
Yeah.
people do not know what the solution is.
Yeah, that's it's a real challenge. We see in human services 40% or so turnover. That has a huge cost associated with it as well, right? Millions of dollars, because you onboard someone that costs money and then they leave in 6 months. It's a problem that we really are looking to confront and have been aiming to confront head on with how do we turn the faucet on so we get great employees coming in, and then obviously plug the drain so that we don't have them leaving. And so we're approaching that really from both angles. From the experience of the interview, to make sure we have the right people in the door. You're absolutely right. I mean, folks can work, and again, in an entry level position. And when I think of entry level at a place like Elwyn or a human services organization, I'm thinking of a direct support professional. So this could be a relatively high school educated person, or even a college person, who maybe has a degree in psychology or something, or could have a degree in anything, but wants to work in the behavioral health space. Yeah, for those folks, looking at a salary of $15 to $20 an hour is kind of where it's at. And yeah, there might be some that are a little bit higher and some that are a little bit lower. But heck, you can make that same amount of money, or maybe even more, possibly working for Target or big box store or whoever it might be, that is not in the healthcare space. And your job, not to say it's going to be necessarily any easier or harder, it's going to be different, but I certainly would argue that direct support side, where you're caring for individuals, where anything could happen. I mean, someone could have a seizure, someone could have whatever medical episode or any other episode, behavioral episode in the middle of the day or the middle of the night. That's different than what you would necessarily see making that potentially same amount of money at a Target or a big box store or whatnot. So yeah, there's a real pressure there. And what we see is we need ways of showing folks, even before they're interviewing, what it means to work in the group home, what it means to work in the outpatient setting, what it means to work in the residential treatment facility. Let's have them walk through the unit on any given day. Perhaps it is that sort of show and tell type modality, so folks can see what they do. It's one of the pieces of information that we've got in many exit interviews that we've done when folks have left the organization, is that this wasn't the job I signed up for. So I think it's on us to show them what the job is that they're signing up for. I mean, obviously, you can't show everything in the sense of you're not there 24/7. But if you can at least, hey, show a clip of it real time, I think it gives folks a sense of what they are signing up for, what they are interviewing for. And truly, we want those folks who are motivated, who are aligned, who really see us as the organization they want to work for, because they want to help people, they want to do the right thing, whatever those additional reasons are. Um, that is a great sense that you can get from an organization like an Elwyn, where a sense of mission driven purpose and such. And so, if that helps facilitate a better hiring process, we certainly believe it will contribute to the retention side because people will be at the organization for more reasons than just the paycheck. Likewise, when folks do get to us and are on our unit, we've got to make sure that they're well trained, and we've got to make sure that we're doing everything to support them. And so, we've seen that with high turnover, you do lose managers and such, and we are very much focused on the management team to really help teach them how to be a better supervisor, how to coach better, how to be a mentor, how to do those things so that when I join the unit and things start happening on the unit, I've got someone that I can go to. We can have all the policies in the world and all the procedures in the world, but if we're not teaching them in clear, coherent fashion, if we're not modeling them, if we're not really pointing to them when the occurrence happens, I think we're losing out. And so we do see the supervisors really being a key link in that chain. And the last thing I'll say is that folks come to Elwyn or any human services organization or any healthcare organization for different reasons. But we do know that there is a segment of the population that this might be their first job out of high school or out of college. And it might be a way for them to get a taste for behavioral health. And it might be a way for them to maybe become the next clinician that's there. And we've seen some really great development from folks whereby we even have relationships with universities where they come as an intern and they might be working for us unpaid, or maybe some of them are working for us paid, but at a pretty nominal amount of money. And they're seeing things firsthand. They're seeing the group homes, they're seeing the outpatient. They get to know who we are. We get to know who they are. And I think many of them find that we're the best kept secret. They find things out about us that they wouldn't have known otherwise. And we really have a great time then. We know who they are, hiring them, and then continuing to foster that relationship. Perhaps use education dollars that they can get through our program. Different types of typically, I think it's like $5,000 or so dollars to be able to provide folks with such stipends so they can pursue their career. So maybe they want to pursue that master's or go for that PhD or PsyD or whatever it is. We want to support them in that growth. We want to, again, really help make this a home for ideally, the rest of their career. Again, that's not for everybody, but I think we need to think about those pathways very deliberately and consciously, because we also need the next generation of clinicians and of leaders and of managers and so we've got to really invest that in our folks. And frankly, I mean, those investments end up being cheap if you're able to turn down the turnover needle. Millions of dollars, much rather have it spent in investing in people, keeping them there. And again, it's all about relationships. So when you're working with folks with intellectual developmental disabilities, it is even more about relationships than those who might not have those same challenges and such. So I think that's it's a multi-pronged strategy. It's not easy, but it's the one that we need to take because it is competitive out there, and we're all competing for many of the same folks. And we want to really show them the best of us and give them the best so that they can be successful and they can drive great quality care for the folks that they're supporting.
I really think that's something that we need to adopt in the United States as a whole, but I think especially in healthcare. In business school, my last course that I was taking last semester, there was an article about how in India the turnover rate throughout the country is very high, right? So it's 40 to 60%. And so they do long-term strategies of implementing education, training, benefits, a lot of the competitive companies. And that echoes a lot of what you're saying, that the environment is so competitive. And when somebody leaves, we're kind of just throwing the money away, right? We're not
Right.
actually investing. Like the money is gone, and it's gone in both scenarios, but at least in one, we could retain some ROI on it. Um,
Absolutely.
and it's hard,
Absolutely.
it seems like we don't always, I think we don't always see that on the spreadsheet, right? You have to look further than the spreadsheet to get the story.
Well, and I think what was it? The CEO of Boeing attributed much of the troubles that Boeing has had to the loss of really, I guess, institutional knowledge from the pandemic. I think that's true of any organization, right? And certainly, again, when you have that high turnover, you're going to lose institutional knowledge. You're going to lose many of the things that you do, and so you're absolutely right. Investing in those folks that you have, hire well and train well, mentor well, retain well. It goes a long way. And again, I don't think it doesn't need a rocket scientist, so to speak, to produce that. But hey, at least we do need to be clear on the map so that we can follow it and go towards it. So yeah, that's our aim, and it really is the calling for certainly last fiscal year and this fiscal year as we look to build upon the investment in our employees.
Thank you so much for sharing all of this with us, Dr. Maselli, and thank you for coming on during your evening after probably a long day and sitting with us for this time. So I really do appreciate it, and I hope we can have you on again in the future.
Love to do it, and appreciate you taking the time with me. Thank you so much.